Welcome to Chiropractic Science, where you get to hear interviews with leading chiropractic researchers from around the world. Hear about chiropractic research from the authors in plain English, not through the media nor a middleman. My name is Dr. Dean Smith, and I am the host of Chiropractic Science. I'm an associate clinical professor in the Department of Kinesiology and Health at Miami University, and I'm also a chiropractor in Eaton, Ohio. My research interests relate to understanding how chiropractic affects motor control and human performance. Today, I have the privilege of interviewing Dr. Tue Jensen. But before we get to the interview, I wanted to thank all of you who have subscribed to Chiropractic Science, and I'm especially appreciative to all of you who have contributed 5-star reviews on iTunes. iTunes really helps others find out about chiropractic science. So, if you like the show, please take a second and write a review. It will support chiropractors everywhere. Someone with the nickname Merciful Chihuahua from Canada writes, "This is an excellent podcast with superstar guest speakers. As a future chiropractor, this podcast is a great way for me to learn and grow from knowledge offered by passionate professionals. Content is insightful and current, a must listen." Well, thank you, Merciful Chihuahua, for your feedback and review, and I look forward to sharing your iTunes review in a future podcast. I'd also like to encourage any of you who may be interested in submitting an audio review, a voice message, if you will. You can just send that along to dean@chiropracticscience.com for consideration to put on an upcoming episode. Well, it's now the new year, and the 2020 update of the Chiropractic Science slides presentation is available to educate your patients and your community about the benefits of chiropractic care. The slides are currently on sale, but as a bonus for listeners of the podcast, you can take an extra $25 off by entering the code podcast25 at checkout. There are now over 365 slides in the presentation. Each slide includes a short evidence-based message from the scientific literature, along with the reference and a picture. In addition, you can customize the slides to your clinic. For more information and for slide reviews, check out our website at chiropracticscience.com. All right, on to the podcast. Well, let's get on to the interview with Dr. Tue Secher Jensen. Tue Secher Jensen graduated from the University of Southern Denmark in 2002 and has been working as a researcher since his student years. After graduation, he worked as a chiropractic intern and as a chiropractor for a couple of years alongside his work as a research assistant. In 2009, he defended his PhD thesis on the prevalence, development, and clinical value of Modic Changes in the general population. From 2013 to 2016, he was employed as a senior researcher and clinical associate professor at the Spine Center of Southern Denmark, and since 2013, he has also been employed as a senior researcher at the Nordic Institute of Chiropractic and Clinical Biomechanics, or NIKKB. Since 2017, he has been employed at the Diagnostic Center Imaging Sector at the Regional Hospital in Silkeborg, Denmark, as a chiropractor doing research and reading spinal MRIs. From 2018 to 2019, he was an associate professor at the Department of Clinical Medicine at Aarhus University. Tue Secher Jensen was recently, starting January 1st of 2020, appointed, along with Lise Hesbeck, who was previously on the podcast, as professors at the Department of Sports Science and Clinical Biomechanics at SDU. Tue's research has primarily focused on the clinical value of MRI findings in people with back pain. In recent years, his research focus has shifted more towards clinical guidelines, knowledge translation, and implementation. Dr. Jensen, thanks so much for coming on the Chiropractic Science podcast.
Well, thank you, Dean, and thanks for having me. It's a real honor to be here.
Well, thank you. And, there's so many questions that I want to ask you, and such interesting material I think we're going to talk about today. I really do think that chiropractors from all over the world are going to learn a lot from our conversation and your knowledge in particular. So let's get started, if you could tell us how you became interested in becoming a chiropractor.
Well, I think my story is very much like many of your previous guests. As a kid and a teenager, I had sporadic back pain, hip pain, stuff like that. And my mother took me to the local chiropractor who did his thing, and I got better. And but I think there is especially one episode when I was a teenager that sort of got me more interested in choosing a career as a chiropractor, and that was I had a fight with my younger sister, as siblings do, and I got an acute thoracic pain, and again went to the chiropractor, but this time I went alone, and it was one of those episodes where you come crawling into the clinic and the chiropractor does his thing and you're 100% perfect afterwards. And of course that was great, but going there alone, I had to pay for myself. My parents weren't there. So when I got the bill, I did some fast calculations in my head and found out that hey, this might be a great combination of helping people and then still having a decent income. So I started to looking into how to become a chiropractor. And at that time, they were talking about setting up the chiropractic education at the University of Southern Denmark. And it so happened that when I got out of gymnasium, I could apply to get into the Danish chiropractic program that had almost just started. I think I was the third generation or something like that.
That's great. So after chiropractic school, what was practice like for you? Did you have a family practice and any kind of specialization? And then we'll certainly get into your research.
Yeah, well, as you said in the introduction, I only worked as a clinician for a very short time and never as a full-time clinician. After graduation, I did my 1-year internship in chiropractic clinic, part-time as being a research assistant, the other part-time, 50% each. And so I had an internship for 2 years instead of 1 year, and got more and more sucked into the research, and then became a full-time researcher shortly after that. So it was a normal, what you say, a normal Danish chiropractic clinic. But I think what I enjoyed most were the more complicated patients with longer history of back pain, and more complicated psychosocial problems. So that was, at least for the last 6 months or so, that was mainly what I engaged with in the clinic.
That's really interesting. Now, I don't know if you'll recall what the research was, but I'm kind of curious, what kind of research were you doing at that time?
Well, again, as you said in the introduction, I started doing research when I was a student. After graduating, after my bachelor's degree, I got into the master's program. And at that time, I was involved as a student member in the study board and the faculty board as a student member, and got to know a few people from the faculty. And one of them was Professor Tom Bendix, who's a rheumatologist and was the head of research at the Spine Center, where the chiropractic students had their clinical training. And at that time, they had just got a large grant to buy an MRI unit and set up a series of PhD studies, including Alice Kongsted, who has previously been on the podcast here. But they couldn't find a radiographer. And because we as chiropractors are taught and can act under legislation here in Denmark, can use imaging equipment, I was asked by the professor if I wanted to spend some months in the unit and in the research center and setting up the MRI system and testing it and trying to set it up for the research projects that they were going to do. So that was basically how I got into it. And pretty soon I did my my master thesis on MRI findings alongside with my wife. And after that, I continued as a research assistant, as I mentioned, and that was also within MRI and looking at disc herniations, as we are probably going to talk about a bit later.
Well, that's fantastic, and that definitely answered my question about how you got into the research, because I wondered how the whole MRI thing happened for you, but that makes a lot of sense now.
Coincidence.
That's right.
So
hey, Tue, can you read their MRIs for us? Yeah. That's great.
Yeah, so I had some basic training by Siemens and took some courses on how MRI machines work, and so we started scanning chickens and steaks, stuff like that. Had a small project with the Department of Anatomy where we scanned a human corpse and dissected it afterwards to look at some of the spinal muscles and stuff like that. So that was a very interesting period while we just had a very, very expensive toy to play with.
Yep, it sounds like time well spent, actually, to be able to correlate the cadaver findings with the MRI findings as well. Yeah. Well, let's talk about many of the studies that you've done and been involved with, and some of the things that you're particularly interested in. Now, you've published in some top journals such as Spine Journal, PLOS One, BMC, Musculoskeletal Disorders, and many others. And we were talking before the podcast of some topics that you thought would be a good idea. And one of the main topics is the clinical value of MRI. And within that, we'll talk about distinguishing amongst asymptomatic versus symptomatic individuals with MRI. We'll talk about disc herniations and sciatica, and does size matter for the disc herniation. Modic changes, which I'm really fascinated about because I don't know a whole lot actually about that. And then single versus multiple imaging findings, and perhaps we can get into some issues about guideline usage for MRI. So let's get started with this idea of the clinical value of MRI findings, particularly in people with low back pain and sciatica, but I guess we'll also talk about asymptomatic folks. And if you could perhaps start us off with, what's the deal with MRI as a paraclinical test, and how does it give us information about diagnosis, treatment, and prognosis? Yeah,
so that's a really good question, and there are, of course, more questions in that. But as you said, it's good. It's a good idea to look at MRI as a medical test, and what you want to get out of the test is to get as much information as possible. And so if you want to take a blood test and test for Ebola, of course, that has some really vital information. And of course, the same would be the the case with MRI for back pain, we would really like that test to be able to either inform us about the diagnosis or choice of treatment, or, as you said, to be able to inform us about the prognosis of the patient. And I would say that the evidence for these three parts are not equally distributed. We have quite good evidence about the first one, about diagnosis. And especially there are two very good systematic reviews that was published a few years ago by Renjicki and co-workers in 2015. One where they gathered the literature about what's the prevalence of degenerative findings in people that do not have back pain. And then they followed that up a few months later with another very good systematic review that looked at the difference in prevalence between asymptomatic people and people with low back pain. So if we take the first one, the main conclusion from that paper is that degenerative MRI findings are very common in people with no pain. So, for example, the prevalence of disc degenerations increases with age, so that when you get above 50 years of age, I think it's, is it 50% of people who have disc degeneration? I can't remember at the moment, but a lot of people have, who are not in pain, have MRI findings, degenerative MRI findings. And I would say that paper has got a lot of publicity, both as references or references in other articles in the subject, but also on social media, to sort of fuel the discussion about that that MRI findings, degenerative MRI findings, are common, and they should probably not be seen as something that is the cause of low back pain. But if you then look at the other paper, the second paper that looked at the difference in the prevalence of these MRI findings between people with pain and those without pain, then the story is a bit different, because it is true that MRI findings are common in people without back pain, but they are more common in people with back pain. So, for example, disc degeneration, which is common in asymptomatics. I think in this review, they looked at people below the age of 50, and I think a third of people without low back pain have disc degeneration. But it's, when we look at the people with low back pain, it's twice as many. It's 60% who have disc degeneration. And that same pattern goes for a number of these MRI findings that they have looked at. Disc bulges, disc degeneration, extrusions, protrusions, Modic type changes, type 1 changes, and spondylolisthesis. So I think it's fair to say that although MRI findings are very common in people without back pain, they are more common in people with pain, and therefore there is a clinical relevance in these findings. So it is possible to say that if you have a person with one or more of these changes, then there is a likely chance that one or more of these changes are associated with the pain. So I think it's fair to say that for the diagnosis bit, I think it's fair to say that yes, it is possible with some degree of error that that if you do order an MRI and you look at the images or the report, that there are different degenerative findings, then it's likely that one or more of these are the source of pain. The problem is that because we have 5 disc levels and we have 5 discs, we have 2 end plates per disc level and 2 facet joints, it can be very, very hard to distinguish or to identify which of these degenerative findings are the main source of the pain.
Gotcha. Yeah. And, it makes me think of, meetings, seminars I've gone to where some of the presenters will say, well, just even sending somebody for an MRI will cause more problems than good. It's really interesting to hear you talk about the difference between symptomatic and asymptomatic. And I just wanted to follow up with a couple of points and maybe get your thoughts. So that first paper that you mentioned, that is such a frequently cited paper. I see graphics all over the place from that paper. And you'd mentioned, the prevalence of people over the age of 50 who have disc degeneration. And I just quickly looked at it because I couldn't remember the numbers either. And it turned out that at 50, there is an 80% prevalence of degenerative disc disease. And by 70, it goes up to 93%. So I don't know if we take that at face value, what do you think? I mean, other than just saying, okay, we have more problems as we age, that makes sense, I think, on the face of it. But do we get any more clinical insight on a paper like that, or do we really need to then look at the asymptomatic / symptomatic differences?
Well, of course, it's as I mentioned with that it complicates that we have different levels or many levels, and it can be hard to pinpoint exactly what is the source of pain. Of course, it gets even more complicated when you have multiple findings. So when we get patients who are above the age of 50, then, as you mentioned, the majority of people, both asymptomatics and symptomatics, will have a lot of these findings and a lot of different findings at different levels. So how do we use that clinically? And I think one of the answers that might be helpful is one study we did with Professor Mark Hancock from Macquarie University in Sydney, where we did some secondary analysis on 2 cohorts that we have. One was from the Danish cohort, Baxon Funen, that I also used in my PhD thesis, where we looked at these 440-year-old Danes from the general population, where we have then both symptomatic and asymptomatic in the same population. And the other cohort was Professor Hancock's cohort from primary care, where they MRI'd people, I think 70 or 80 people, who had just gotten over an episode of low back pain, and then they followed them for a year, and then the people had to report in when they got a recurrence of their back pain. So in this paper, we, instead of looking at the single MRI findings versus pain or recurrence of pain, we looked at the number of MRI findings and see if there was a sort of dose response so that people with more MRI findings were more likely to have pain or were more likely to have recurrence of their pain within the past year. And logically, you would assume that that was the case, that the more findings you have, whenever, as we have from the second PRINCIQ review, that some of these or many of these MRI findings are single-handed associated with pain. And then if you have more of those, you would be more likely to have pain. And that was the case. So when we compared people who had 3 or more MRI findings, and that would be disc degeneration, disc herniations, Modic type changes, stuff like that. If you had 3 or more of these changes, you were much more likely to have had experienced low back pain within the past year than if you didn't have any of these degenerative MRI changes. And also, if you had if you have had an episode of back pain and that episode had resolved, again, if you had 3 or more MRI findings, you were much more likely to have a recurrence of your low back pain within the following year if you had these MRI findings. And I think, on the top of my head, if the patient had 3 or more MRI findings, I think it was 75% of them, of that group, who had recurrence within the next 12 months, whereas it was only 10% of those who did not have any of these MRI changes. They were the reference groups. So I would say the base conclusion of this is that, yes, MRI findings are associated with pain, and the more you have, the more likely you are to experience pain. So,
yeah, that makes sense. And I just thought about another question to ask you when we get to the multiple imaging finding. So I'm racking up more questions as we get deeper into this. But the next topic is super interesting. And this is disc herniations and sciatica. Does size of the disc herniation matter? And I was a little bit blown away by some of the information that you gave to me to look at. So perhaps you could just get us into this topic of how you guys started studying this and what you've learned so far.
Yeah. Well, this was actually the first proper research project that I was involved with. And it was one of the first studies at the Spine Center where the MRI, this at that time, new and fancy equipment came into use. I have to say it was that it's 20 years ago when we got that MRI machine, and it's of course no longer in use. It was a 0.2 Tesla scanner, which is a low field scanner compared to the ones that are in use today, which are usually 1.5 Tesla or 3 Tesla. And so, of course, the MRI technique has evolved since then, and we might get back to that later on. But so back to this study about sciatica. This was actually a study that was on top of a PhD study by Dr. Hannah Albert, the researcher who did the first Modic antibiotic study. And it was actually this her PhD study that started to to get us these ideas about modic changes as being a source of pain in patients with low back pain, or people with low back pain. So in her project, they looked at patients with subacute sciatica. So it was a two-armed RCT. Patients were randomized to either active non-surgical care and what you would call hands-off or natural course. And the part of the project that I was engaged with was the MRI stuff. And what we did was that we did an MRI at baseline when patients were enrolled, and then 14 months after baseline. So that would be 12 months after that, the treatment period. And as far as I remember, there were 180 patients enrolled at baseline, and I think we, in the two articles that we published, I think there were 154 or something like that that had MRI at both baseline and follow-up, 1 year follow-up. And we did two papers. One from 2006 came out in Spine, and where we tried to describe the natural course of disc herniation over a year. Of course, we only had those 2 time points. And I think there were 2 relevant conclusions from that study. One was that because apart from looking at the natural course of the disc changes, we also want to investigate if it was possible to identify the symptomatic disc level from the clinical findings. So one conclusion was that yes, it was possible to identify the symptomatic disc level from the clinical findings that the clinicians had recorded at baseline. Actually, in 90% of cases, it was possible from the nerve root test and the pain drawing and the other information that we had from the patient and the clinical exam, that it was possible to pinpoint the side, left or right, and the approximate level of the disc herniation or the nerve root compromise. And I think that's quite an important conclusion that tells us that maybe as a clinician, when you have a patient with acute or subacute sciatica, that it's okay to wait with that MRI scan because, as I said, in 90% of cases, you're actually able, with a proper history and clinical examination, to get with 90% certainty an estimate of where that nerve root compromise is. And most likely it is a disc herniation. So I think that's very important because you don't need the MRI to confirm that there is a disc herniation. Your clinical examination and your history, the patient history, can guide you to that same conclusion. And I would say then the other relevant conclusion from that study was that we found that the larger the herniation is, the more likely it is to reduce in size over that 1 year period. And I think that was, at least for myself, that was not what I had been taught in university. Because what we found was that, well, if the large herniations and sequestrations, if they are those who get better by themselves, then there shouldn't, at least if there are no red flags, would look like they would be the ones that you should leave alone and just let nature do what it does best. So that was the first paper, which were pretty much just about the course of a disc herniation over time. And then the second article from 2007 was where we tried to see if, because it's very rarely that you, for a patient, would do 2 MRI scans with 12 months apart. So if you do an MRI scan, of course, you only do one, and that is when you see the patient and things doesn't quite go as planned. And then we would like to try and get information that could inform clinicians on how to talk about prognosis for their patients with sciatica. And that, I think the main conclusion from that paper is that, well, first of all, there was actually no difference between the 2 treatments that was in this randomized controlled trial. And secondly, we found that, again, when you have your baseline scan or you have your MRI scan of your patient with sciatica, it was quite clear that the patients who had the large herniations, that would be the broad-based herniations or extrusions, those were the one who had the best chance of recovery after 1 year. And at least here in Denmark, that came to some pretty heated discussions with some of our surgical colleagues, because at least when I was in university, our textbook in orthopedic surgery said quite specifically that these large herniations and sequestrations, these were the ones that should be operated upon, because that would give the best result for the patient. But what we found here in this study, and had at that time also been shown in a few other studies, was that, well, doing nothing or providing non-surgical care for these patients also gave better results when there was a very large herniation.
Yeah, this is just fascinating discussion, because you're exactly right. And what the surgeon said to your group is exactly what I imagine would be said over here in the United States and Canada, across North America, and I'm sure across the world. And that is, you just wouldn't expect that the larger the disc herniation, it seems like the better the outcome at 14 months, which is exactly what you found, which is, it's amazing. So, I mean, most of the time I would think a surgeon or a chiropractor, if they were to repeat the scan, they would assume, hey, this disc herniation got much smaller. That would be their sign of success.
Yeah. But it looks like that's just the natural course. And maybe there is some evidence that suggests that what the big herniation does or do is that they trigger a larger immunoresponse. And so the cry for help is much larger than for the contained discs. And it activates the cleaning up by all the macrophages and what have you. So if you want to have a herniation, do it properly. Get a big one.
Oh, I like that. but we've been conditioned to think they're so bad.
Yeah, and of course, I haven't had one, luckily, yet. And I do have good colleagues who have had large herniations, and with this information have gone through the hard phase of taking that nasty pain that you have. I've been told that you have when you have a disc herniation. It's not something that I think you would wish for anyone. But I think with this information, you can say that, well, as long as your pain is getting better gradually, that's a good sign. And yeah, keep on doing what you can do. And of course, if there are some absolute indications of surgery, so when you have paresis or cauda-equinus symptoms or something like that, then of course you should get referred for surgery. But as long as you have that steady good course, there is no reason to do neither MRI nor surgery.
Yeah, that's a very good point. I'm glad you made that. I laughed a minute ago, but that's the serious part of it. You don't want to mess around with something that looks like it's going bad, and but otherwise, the flip side of the coin is, okay, well, maybe we can just sort of, as the disc is healing, we can provide our chiropractic care or our exercise or whatever treatment, and hopefully keep it on the conservative side of things.
Yeah. I think, as I mentioned, there wasn't any difference between the two treatment arms in this study.
Uh-huh.
And I may want to just clarify what the two treatments were. And they were both non-surgical treatments. And so what was the difference between the two groups were that one had active treatment, and that could, which was multidisciplinary. It was at the Spine Center at that time. So it was both physiotherapists and chiropractors who did that active treatment, and it consisted of symptom-guided exercises and optional manual treatment. And for the control group, they got sham exercises, and that was something like flexing your foot and moving your arms. Nothing that could affect your lumbar spine. But what both groups got was that they got tender loving care. They got thorough information about anatomy of the spine and the natural healing process of herniations, and they got the staff that they met and talked to were supportive and acknowledged their pain, the patient's pain and disability. And then on top of that, if it was necessary, they were allowed to have weak analgesics, so paracetamol or NSAIDs.
Okay, great. I appreciate you going through that. It makes a lot of sense as well, especially the part about, just letting patients know that, things are likely going to be okay here, and here's what's going on, and here's what we know. And so that's all good stuff.
Yeah, and I think another important point is to monitor the patient so that you can, of course, if it's true, tell the patient that, well, we're making progress. It may be slow but steady progress, but there is progress. So they can be reassured. I think that's quite important.
Absolutely. Yeah. I mean, that's my patients want to know that, what are things going to look like, and are they going better or not? Absolutely, for sure. Well, thanks for going through all of that. The next topic that I'd like to get into is a topic that is relatively new to me. I'd say probably 4 or 5 years ago was the first time I had ever heard of this term, Modic Changes, with reference to the spine. So could we start out with what is a Modic change, and then talk about a couple of the papers that you've been involved with?
Yeah, sure. Well, Modic changes are basically changes in the vertebral end plate and the subchondral bone marrow. They're called Modic changes because Professor Modic, who's a radiologist in Chicago, was the first one to describe these changes systematically, how they look and how they develop over time with that material he had back in 84, I think. So he described 3 types of changes, type 1, 2, and 3. And type 1 changes are where you would see edema in the vertebral end plate and the bone marrow, adjacent bone marrow. The type 2 change is something that usually comes when we look at these in a longitudinal perspective. The type 2 changes are something that comes after type 1 changes. So, and they consist of fatty marrow changes. So that would be usually when you have a bone with red bone marrow in it, as we have in the vertebra. Then when that red bone marrow, hematopoietic bone marrow, is displaced, it is displaced, then it is replaced by yellow fat. And that is what we see as type 2 changes. And then we have the type 3 changes, and that is the sclerosis. So when you have, when the trabeculae and the end plate gets thicker, you can see that not as much on MRI, but more on radiographs and CT scans. And usually we see them at later stages when people are, over the age of 50, 60 years of age. What we know from the literature, I did a systematic literature review as part of my PhD, where we looked at the prevalence of Modic changes in different population and different age groups. And what we found was that Modic changes are rare in people, in young people. But as you become older, the type 1 changes begin to appear, and then the type 2 changes begin to appear some year after that, when we look at it as at a population level. And also when we look at it at a patient level. So usually you will have to be in your 30s or your 40s to have Modic changes. Below that age, they're quite rare. But when we get into those decades, it's about a third of patients with low back pain who would have either type 1 or type 2 changes. In the research group that I used to work in as a research assistant when we did this PhD study that we talked about on the sciatica patients, that was done in the same period of time as another PhD was done, this study with the 440-year-old Danes from the general population. So these 2 studies ran at the same time, and they basically came up with the same conclusion, So in the sciatica trial, what Dr. Albert found when she talked to the patient at their 1 year follow-up was that, yes, they were relieved of their leg symptoms, so they didn't have sciatica anymore. But a large proportion of the patients had really severe back pain. And at the same time, he's a professor now, Per Kjær, who did the epidemiological study on the 440-year-old Danes, came up with, when he did his first study, found that these Modic changes were associated with low back pain. So we had in the center, we had two studies that gave us sort of an impression that what we saw, these white spots in the vertebrae, which at least here in Denmark, no one had talked about, they suddenly seemed to be clinically relevant. And that, that sort of generated a whole lot of studies, including my own PhD, that in these 440-year-old Danes, we did 4 and 8 year follow-up of those, and that was what was included in my PhD. But also, we did a lot of thinking about, well, what are these changes? Because at that time, we're in 2005 or 6 at this time. And more or less all we could find in the literature about these changes were these papers back from the 80s that Professor Modic had published. So we published a hypothesis paper and tried to come up with what we thought were or how to categorize these changes, because when we looked at in the textbooks, if you had these white dots, your Modic changes, if you had something that looked like that and you looked in your textbooks, then you would either have infection or you would have inflammatory changes, so spondyloarthropathies, stuff like that. But it was clear to us that the patients we had seen in the sciatica trial and also in the epidemiological cohort study that we did, that these people did not have inflammatory back pain or had infection. But maybe they could have an infection, because some of them had these irregular end plates. Some of them had also bright central signal from the degenerated discs, which can be a sign of discitis. So in the hypothesis paper, we came up with 3 hypotheses, and one was that, yes, it's true. It's likely that some of these changes could be due to inflammation, so spondyloarthropathy. And yes, there was also some that could be bacterial from virulent bacteria, so that would give you discitis and a big infection with pus and all that need surgical treatment and antibiotics. And then there were the biomechanical hypothesis, where when you have disc degeneration and you maybe have scoliosis and you have the end plates of 2 vertebrae started nearing each other, bone growth will appear, and part of that bone growth will of course involve more blood vessels in the area, and that would be seen as Modic type 1 changes. But what really was interesting was that at the same time, one of our radiologists came back from a conference and heard a British professor talking about low virulent infections. And with these anaerobic bacteria called Propionibacterium acne. And we started to speculate whether it was possible for these bacteria to get into the disc and make a non-virulent infection, a slow infection that wouldn't be aggressive as the ones you see with the more aggressive bacteria. And at that time, and the discussion is still ongoing, whether these Propionibacterium acnes are present in the disc or not. But that was what led to the first antibiotic study by Dr. Albert, which reported quite a large effect for these patients, especially those with Modic type 1 changes. Maybe this is a good place to
so
take a pause.
So now, if I understood that last part correctly, did the study by Albert find that antibiotics did have an effect?
Yes.
A
quite dramatic effect, and one that would keep on giving after end of treatment. So usually what you would expect, usually when you do RCTs on patients with back pain, you do a treatment, people improve, and then usually you do a treatment over weeks or maybe a few months. And then when you do 1 month or 1 year follow-up, people would have recurrence of their pain, so their pain or disability will have increased after a year. However, in this study, actually people were even better after a year than after end of treatment, which was a bit out of the ordinary. So that got a lot of publicity, both good and bad, I would say. And then we have been waiting for a replication of that study. And luckily, last year came the results from the AIM study that they did in Norway, which didn't find the same. They didn't come to the same result. I think their conclusion was that they do not support the use of antibiotic for patients with Modic changes. So, that question is still open, I would say. So we have one RCT that says that there is an effect of antibiotics, and another one that says that there isn't.
Yeah, I at least in my area, I have not seen that come into clinical practice where patients with chronic back pain are given antibiotics. I just have not seen that at all. So I guess in this case, that might be a good thing, especially with the second paper, suggesting actually even that not only wasn't there really any clinically meaningful change, but that there was more side effects also.
Yeah, and that is one very important note, and that is that when you're giving high dose antibiotics for 3 months, it is quite likely that you will have side effects. So anything from diarrhea to fungus infection and stuff like that. And then there's, of course, the what do you call it? Antibiotics when they get resistance.
Yep.
That if you broaden this out and you wanted to treat a third of patients with low back pain with antibiotics, the third of low back pain patients who have Modic Changes with high dose antibiotics for 3 months, I'm not sure that would be, from a societal health perspective, would be very wise.
Right, for sure. I wanted to ask one question about that hypothesis paper that you had with the 3 different possibilities. One being that it could respond to antibiotics. And I think the third one you mentioned was a mechanical sort of hypothesis to the Modic change. Just wondering, when I think about inflammation, I think, okay, there's acute inflammation, that would typically respond to things perhaps like ice and non-steroidal anti-inflammatory drugs and things of that nature. And then I think of more of a chronic type of inflammation, a rumbling type, if you will, that's kind of in the background, that's a lot more difficult to detect with our, typical methods. And it also makes me think about tendinopathies, where we used to call them tendinitis because we used to assume that there was some sort of acute inflammation going on, and now we sort of think it's a degenerative sort of condition. Do you think there's maybe some in that mechanical group or mechanical hypothesis? Do you think there's some room for kind of a chronic inflammatory thing that's going on there?
Yeah, I would say that that's one of the limitations we have with MRI, is that MRI is a technique that is very good at identifying edema. So when you use stir imaging or T2, but for example, stir imaging, it is very precise at identifying where there is edema. But edema is not always inflammation. So you could have edema, for example, as I said, when you have spondylosis, you have spondylophytes, and you would have that maybe reactive edema while the spur is building, because of course you need the nutrients and blood vessels to that area to build the bone. And that's not necessarily pathological. That's just remodeling of the bone, and not necessarily something that would be associated with pain. On the other hand, you can see if you have a small impression in the end plate. So when you basically have a disc herniation that goes through the end plate, you have destruction of the end plate and the trabecular bone, and you get a response, inflammatory response to that. You will see on the MRI that there is edema in that area, and that would probably be inflammation and be associated with pain, and then will be remodeled, and then you will have a small area of fatty degeneration in that area when it has healed. So it is difficult to come with an exact answer to your question.
Yeah, no, I totally get it. And, just looking at sort of the natural history of, if you look at a long bone, red marrow is typically replaced with yellow over time. And that's sort of just a natural consequence. At least that's my understanding over time. Perhaps inactivity and some other, other factors are playing in here as well. But yeah, it's interesting to think about all these possibilities. And I appreciate that insight of how MRI is picking up on certain things, and we may not have access to, understanding whether there is some sort of low-level inflammation that may not be caught or something like that?
Yeah. There are actually some quite good papers out there that have identified these acne bacteria within the disc in patients who have had disc herniations. And so that theory is still viable. The question is still, should we do anything about them? Should we just, are they there by coincidence, or do they cause trouble when they're there?
Right. Yeah. It's interesting. Yeah. It makes me think of something from our area about where's Waldo. I don't know if you've heard that phrase before. Is Waldo hanging out in the disc or not?
Yeah.
And does Waldo have anything to do with anything?
Yeah, exactly. And and again, as we wrote in our hypothesis paper, so these changes that we see on MRI that we call Modic changes, they are probably also multifactorial. So some of them may be due to this low virulent infection. Some are due to small fractures. Some are inflammatory, and some are purely biomechanical or load come from change of load because of this degeneration. So yeah.
Cool.
There are still questions to answer.
Yeah, as always, lots more questions. I'm digging this conversation too. This is great. I'm learning a lot, and we still have a little bit more to go. So the next thing I wanted to ask you about was single versus multiple imaging findings, and you'd mentioned a paper early in our conversation about single versus multiple imaging findings. And basically, it seems like the gist of it is that if you do have multiple imaging findings, that you have a greater likelihood to have low back pain.
Yeah.
Perhaps we can expand on that a little bit, and then I have at least one question to ask you about the topic.
Yeah.
So, well, maybe I'll just go ahead and ask you the question that I had early on when you were talking initially, and that was that if we have these multiple imaging findings, okay, so maybe disc herniation, disc degeneration, end plate change, modic change. I'm assuming these are all different types of the imaging findings that you're talking about. Is it something like multiple comorbidities that a patient might have? So like diabetes, and they have cardiovascular disease, and they have obesity. Now I realize we're talking about the spine here, and this is perhaps one system, and maybe it's not fair to compare these comorbidities as what some people say, but is that in essence kind of what we're talking about?
I think so. One of the challenges that we have tried to give ourselves at the University of Southern Denmark, the research group I'm working with, is that we're trying to distinguish between what we started out by talking about, normal age-related changes that we assume are not painful, and then those injury-related or frailty-related imaging findings that look the same as the age-related findings, but they do cause pain. And I must say that we haven't found the right answer to that question. But what we do know is that when we start out with a fresh disc and normal disc, what we can see is that that when you have, for example, one disc degenerative finding, that could be the thing that starts a cascade for that discovertebral segment. So when there's a hole in the disc, in the balloon, and start to reduce in height, so the pressure, the pressure that is within a normal healthy disc, it sort of is released either by a radial tear in the disc going through the annulus or small cracks in the end plate, and it starts to loosen that pressure. It looks like that is something that accelerates the degenerative changes as a whole in that discovertebral segment. So when the disc reduces in height, it puts more load on the facet joint, and then you get facet joint degeneration. And that sort of talks into that discussion about single versus multiple MRI findings. So you could say that first time that you get an episode, or there is a crack in your end plate and you get end plate changes, Modic changes, that could cause pain. But then that heals. And then maybe you get a radial tear through your annulus, and that gets you another episode of back pain, and then it sort of continues and accelerates, so that is maybe why we get these numbers from that single versus multiple MRIs finding study that we did, where we find that the more changes you have, you're more likely to have experienced pain, and you're more likely to have a recurrence of your pain.
So what I hear, what I'm translating in my own brain, and this may not be correct, but what I am visualizing is that the MRI changes, especially multiple changes, may be telling us a bit of a story, like the history of the person and what they've gone through. And that if you're seeing multiple imaging findings, particularly at a single segment level, then it's probably not an acute thing that just happened, but likely has taken a bit of time, and we could only imagine what, types of things have led to that.
Exactly. And of course, then there is the whole variety of what you do and how, as a person. So maybe if you're, I'm sorry to use that analogy, but if you're sort of moving on with a flat tire, and so you run a marathon or something like that, as compared to just sitting in your chair and do sedentary work, there's probably a difference in how these changes will react to that load that you give them.
Tue, are there any history or physical exam findings that a doctor could do or a therapist could do that might predict these multiple MRI findings?
Not that I'm aware of. And it's not that we haven't tried.
I'm sure.
I remember a study many years ago where we tried everything from electric toothbrushes to hammers and different clinical tests to see if we could correlate these clinical tests with particularly MRI findings. But no. And the few studies I've seen published on it reached the same conclusion, that it's very difficult from the clinical examination to identify the specific source of pain when you want to correlate to a specific MRI finding, except, as I started talking about with sciatica, when you do that battery of history taking and your clinical examination of nerve root compromise, then you, at least from the study we did, you can reach 90% accuracy on the level hand side of the disc herniation. But that's only that single MRI finding, that's not multiple MRI findings. So the answer to your question is no, unfortunately.
Okay. So I think that lends nicely into the next question, which is what or when, I guess, what is the advice you would give to chiropractors when they are considering ordering an MRI for the back or the neck?
Well, I would say that we didn't go as much into the choice of treatment or the prognosis bit of the three themes we started out with: diagnosis, treatment, and prognosis. So, but if we take a broad perspective of this, I would say that there is only evidence of MRI being able to give to inform on your diagnosis on what type of tissue could be relevant in this patient that you have. But if that information doesn't inform your treatment or your prognosis in very high detail, then I would say that you should, as a clinician, stick to the clinical guidelines that are out there, both international and national guidelines that says that you should only order an MRI if you have suspicion of serious pathology, and that would be cancer, fracture, infection, inflammatory diseases, and that sort of stuff. Or if your patient if you suspect that they have cauda equina or rapidly progressive neurological deficit. And the last one is that if your patient have persistent or progressive symptoms during or following some weeks, up to 4 to 6 weeks of non-surgical treatment, then I think it's that's where an MRI comes in handy. So it's not like that you want to use MRI as a nice to know, but it should only be used as a need to know, on a need to know basis. And I have heard colleagues, both chiropractors and doctors and physiotherapists, arguing that the MRI could be used for information of the patient. And I think that is very tempting, to use the information that you get from the MRI or the narrative report, to use that as information to the patient, where you try to calm them or give them an explanation about what's wrong with their back. But there is also evidence that this information, that it may cause the patients to worry more, or maybe even focus on their back pain, or avoid to do activity that is recommended in the guidelines. And then you need to be aware that when there is an MRI, then it doesn't go away. You can't undo an MRI. So that information will be out there. And as tempting it is as a clinician to use that information, you don't know where that information will end up next. So you might be a very, very skilled clinician and be able to reduce anxiety or use the MRI information in a good way, but you don't know who the patient will see after they leave your clinic. And you don't know how the next clinician will respond to a very large herniation.
That's exactly what I was thinking of too. You get the X-ray and wow, there's a big disc herniation. Yeah, what are they going to think?
Yeah, let's do
for sure. Oh. Yeah, absolutely. That's exactly what I was thinking. Yeah. I mean, I think that would be a natural response, but given what we've learned today, we have to rethink this. Big time. A fascinating discussion too. I've learned a lot, and I have more to read about this, obviously, to get more in tune. So this is great. I do have one last question. I ask every guest of mine, if you were going to give some advice to a chiropractic student or chiropractor who was interested in starting a research career, what advice would you give?
Well, I think the most important advice I would give is that you should always pursue your curiosity and the ideas that you get when you're doing clinical work. I think we have very good examples of both students and very experienced clinicians come up with research questions that have come up with vital new information, or maybe breaking down myths that exist. So I think that would be my advice. And then, of course, if you do get that idea, or you want to pursue the curiosity that you have, then drop us a mail, call us on the phone. I think that most people in our community know someone, either from the student years or from when you have met at a conference, that works in academia, that might be able to give that idea that you have a life, maybe in research or otherwise.
That's great advice too. Great advice. And I would say that I think our research community is quite nice, quite friendly, very approachable. So
I think we are.
Yeah.
But I'm biased.
Me too. Well, thank you so much, Tue. This has been just an illuminating conversation and very enjoyable. So thanks for coming on.
Well, thank you. It was a great pleasure.
Thanks again for listening to this episode of the Chiropractic Science Podcast with Dr. Tue Secher Jensen. We had an interesting discussion, and I hope you learned something valuable from Dr. Jensen's insight today. Stay tuned for more great episodes of the Chiropractic Science Podcast.